Welcome on our second video on multiple long-term conditions, or MLTCs. My name is Dr. Ghanshyam Kacha, and I work as a primary care fellow at the Leicester Diabetes Centre. In our first video, we discussed an introduction to MLTCs, and we'll share the link on our description below. On this second part in our video series, we're excited to be joined by Professor Kamlesh Khunti. And we're going to be talking more about the clinical aspects and the future of MLTCs and opportunities. Professor Kamlesh Khunti is a professor of primary care diabetes and vascular medicine at the University of Leicester. He's a director of the NIHR ARC East Midlands and a co-director of the Leicester Diabetes Centre. He's also been awarded a CBE for services to health in 2022. So that's an amazing achievement. Professor Khunti, just to begin, I wanted to kick off by asking you, what do you feel is the big challenges around MLTCs?
I think if you look at all the data, we are living longer. And over the years, we've been living longer, which is great news for the patients. But the predictions are that we're living longer, but in poorer health for longer. And so that's the biggest challenge, that we want people to live longer, but we want to make them live in better health for as long as possible. And I think that's the big challenge for healthcare professionals like ourselves and patients themselves, because there are lots of things we could do to make that happen.
That's very interesting. So we're kind of doing really well to keep people living longer, but it's sort of how do we tackle that issue with because age and contributes to MLTC as well.
Absolutely.
And you have this unique perspective as a practicing GP and a researcher. So how do these roles complement each other?
I think it's difficult to do research unless you're also a clinician, because you see all the problems and the challenges we're facing at the coalface, and majority of patients, as you know, are managed in a primary care setting. And we do manage them holistically in a primary care setting. That's the exciting thing about primary care. And I've been a GP for 35 years now, and in the same practice. And I've seen the demography and the profile of my patients change over time. And there's a couple of reasons. One is obviously they're living longer, which is great, but there's so much we can do for them now. Previously, we used to take a high blood pressure before the UKPDS, for example, came for diabetes. Something that was high, we would say that's fine. We will review them on an annual basis. Now, with the research evidence and the pace it's coming at, we're trying to implement that research evidence into clinical practice to try and bring the targets down for all various conditions. And I think that's a real challenge, because our consultation rates have increased enormously. So in my practice, we have 10,500 patients, same number of patients we had 35 years ago. Our consultation rates were about 4 per person per year.
4 per person.
But now it's around 8.5 to 9. So we're seeing them twice as much.
It's like double the amount.
And that's not just because of patients' demand, but because we're trying to bring them proactively much more.
I see.
To try and manage those risk factors and the conditions with the latest evidence base.
Okay, that's quite interesting. It's not that they're just coming to us. We're actually proactively needing to review things and do things for them. It's interesting how over your general practice career, you've seen a change and today. And do you think MLTC has become more important today than it has been in the past?
My patients are definitely more complex now than they were 35 years ago. And as I said, they're living longer, they're accumulating the diseases. And the problem is that our general practice as it is now, it is antiquated. We need to start thinking about working differently. We were on 5-minute appointments when I started, then we went into 10-minute appointments. And now 10 minutes is not enough, and we're on 15-minute appointments for certain patients. And even that we're struggling with, because there's so much to deal with in that 15-minute consultation for that patient.
That makes a lot of sense. Yes, we are constrained by time in general practice, and other healthcare professionals with their appointments have to stick to a time per appointment.
Exactly.
What advice would you give to younger doctors or healthcare staff in managing MLTCs and the time kind of balance?
I think we need to start thinking a bit differently the way we're managing. And there is a potentially exciting future ahead. We've got the 10-year plan.
Yes.
It's talking about neighborhood health centers, managing people in the community more holistically. And I think we need to look at our skill force within primary care and community care and have different people working smartly so that primary care practitioners, for example, may be looking at patients with the very complex conditions. There's really good studies out there, but we're not implementing them. For example, there was a study a few years back showing that the receptionists can screen for atrial fibrillation.
Oh, right. Okay.
And we've got fantastic healthcare assistants, we've got pharmacists, we've got nurses, and they're all highly skilled people.
Yeah.
But having them working in a smarter way so that most of the patients with, simple things are managed in a holistic way within that skill set that we've got in a community setting.
Yes.
And then the complex patients being seen, and not just by general practitioners, it may be even multidisciplinary teams, and we could do telephone consultations with our specialist colleagues where the patients are extremely complex.
Yeah.
And that's already happening in some areas. The cardiometabolic renal conditions are being managed by primary care and secondary care just by remote consultations.
Yeah.
So there is quite a lot we can do. Also, in terms of self-management program for patients, getting them the empowerment so that they can manage their conditions. But I think the one thing we shouldn't forget is that we can prevent these conditions, and we're not doing a good job at trying to prevent these conditions. And that's your public health strategies, such as smoking cessation, diet, and exercise. And exercise, we know, if you're exercising to the level that's recommended, 150 minutes or so per week, you can reduce the risk of accumulating multiple long-term conditions. The other big problem is that once you get one condition, your acceleration of getting the second, third, fourth condition is much, much quicker.
Okay.
So if you can prevent that first condition happening or the second condition happening, then you've got a really good chance that person can be disease-free without accumulations of those conditions for longer.
Okay, that's interesting. Is there a reason why there is this acceleration when...
We're not sure exactly why, whether it's pathophysiological mechanisms that are accelerating this, or is it because once you accumulate one or two conditions, you're not able to do all the lifestyle factors that will reduce your risk of getting that additional condition downstream.
Okay, I see. So you mentioned about the 10-year NHS plan, which has recently been published, and they've put into prominence MLTCs and prevention and sort of moved to the community.
Yes.
You mentioned one of the interventions around neighborhood health centers. How would that impact a population with MLTCs, do you think?
I think what we can do, because it'll be in a geographical area, we can profile our population.
Yeah.
And say, what are the conditions that people have in that area? Because every area will be very different.
Yeah.
And there'll be age differences, there'll be ethnic differences, there'll be socio-demographic differences. Once we profile that area to say, what are the needs of our population?
Yeah.
Then you can start, I think, with a clean sheet and say, well, this is the population. And we're thinking about like a pyramid to say, this is the population at the bottom, which needs the primary prevention.
Yeah.
And then the middle is those with the conditions, and it may be single conditions or multiple long-term conditions, and have those being managed by the wider healthcare team. And then you have that top pyramid, I think, which is about 7% of very complex patients who are likely to be admitted to hospital and come back and then go back into the hospital, having a lot more time to manage them more holistically to ensure that they have all the risk factor controls and anything else that's needed in terms of social care aspects are also delivered within a primary care setting so that all their needs are met with the reduced risk of them going back into hospital. Okay,
it's an interesting idea to stratify the population and see it as one blanket.
We don't do that at the moment. Every patient is seen in a normal way, as you know. But I think this is quite exciting that if we can get this right, we could make a big difference, not only in terms of reducing the healthcare burden that the NHS is facing, but potentially improving the lives of people as well.
Yeah, okay, that's really good. And practicing out of Leicester, where there is a high ethnic minority population, and do you feel neighbourhood health centres or this kind of new innovations do they work better, or is it more challenging, do you think?
I don't know, because we haven't tested this out. I don't see why it shouldn't work. Obviously, the funding has to follow where the care is being delivered. Yeah. We also know there are even more special challenges for people from ethnic minorities and people living in deprived areas, because they get MLTCs at a higher prevalence. They also get them at a younger age. And so either preventing it or managing it and getting that population back into contributing to society through work and pensions, etc. I think it's a really, really important challenge that we need to tackle, because we know more and more younger people are accumulating these diseases. They're not contributing to the economy itself. But if we can prevent that and manage them appropriately, maybe we could again change that as well.
Okay, that's really interesting. So you talked a lot about the preventative sort of targets like exercise, diet, and sort of engaging with healthcare. But there's been some exciting developments in the therapeutic side.
Yes.
We've seen kind of an expansion in research around drugs like SGLT2s, GLP-1s, which have multiple uses or licenses. What's your experience been in implementing these medications to your patients?
I mean, it's been really, really exciting. As you know, these drugs were initially developed and marketed for diabetes, but then there are so many other additional benefits, as you mentioned. SGLT2 inhibitors, tablets now have gone off patent, so quite cheap. And so for heart failure, kidney disease, diabetes, all of those have got robust benefits. So we can certainly use them in those conditions. Whether we can prevent those conditions, high-risk population, there is some data coming out that we can do that as well. So I think even for prevention strategies in high-risk populations would be good to use them. GLP-1 receptor agonists now we get even more powerful. GLP-1 receptor agonists, dual agonists, triple agonists coming out. And the weight reductions we're saying are astonishing, similar to bariatric surgery weight reductions. And again, we know obesity is associated with over 200 conditions.
Oh, right.
And so when we use these therapies, if it can reduce their body weight, it will obviously have an impact. Not only what the trials have tested them on, so these are, again, cardiometabolic conditions, heart disease, kidney disease, strokes, but also other conditions such as obstructive sleep apnea and liver diseases. But I think they may have even wider benefits. Because if you're going to have weight loss, it will help people, for example, with osteoarthritis, because weight is associated with the mobility. We know people who are more obese, they have more exacerbations of things like asthma, COPD. So there may be other off-target benefits that you may get, but they haven't been tested robustly in the trial programs. As well as that, the quality of life, whether that is improved, it's been shown certainly in certain trials, but not in the wider populations that you and I manage in a primary care setting. So there's lots of work still that needs to be done. And then to see, do these therapies help reduce you accumulating other conditions in the longer term? We don't have those data because most of these trials were of short duration, anything from 2 to 5 years. So quite exciting times. I'm sure these GLP-1 related therapies will also go down in price over time. But I think we still need to emphasize the lifestyle. I think people who are on these therapies, sometimes they think it's a quick fix. But lifestyle has so many other wider benefits, so we need to continue emphasizing that.
Yeah, no, I completely agree. Like, it's not a replacement for lifestyle. It's a sort of complement if it's suitable for the individual. But yeah, I completely agree that it's an exciting time to be in, especially with MLTC research. If you can prescribe a drug that has multiple uses, then we're just winning on that front, really. One thing that I wanted to pick your brain about is this issue with polypharmacy in multiple long-term conditions. obviously with somebody who has more than one condition, two conditions, they accumulate a lot of medications, and we are getting really good at finding the new kind of drugs that help. And how do you balance this competing interests?
It's a great idea. There's two issues with this. First of all, when people need the therapies, we keep adding. But what happens is if you've got multiple conditions, and our research has shown, other research has shown that we are less likely to put them onto that additional drug that's going to benefit them. We delay it because it's a complex patient. There's so many other things going on. There's so many therapies, and there's a delay in using that therapy in an appropriate time, such as an SGLT2 inhibitor. So that's one issue we need to tackle. There's the other end where patients are getting old, they're getting frail. They don't need these therapies for blood pressure. They may not need them for glucose. Now they're in a nursing home, they're frail. And I think we need to start thinking about stopping or de-escalating or de-intensifying therapy as well. So there's those two ends. In terms of the number of pill burden that patients have, as you say, it is increasing. And we are a country that doesn't use fixed dose combinations.
That's right,
And, I go to India and give talks there. For example, for diabetes, they've got one therapy with triple combination. But for some reason, we just haven't used them as much in the UK. And I don't know why. There's complex reasons for this.
So there is this mass expansion of artificial intelligence, and it's disrupted a lot of industries. What's your opinion about healthcare and AI or MLTC? How would that all work together?
I personally think it's early days still. There is a lot of MLTC that's happening in real-world data. We and many others are involved in that, looking at clustering and trajectories and things. Whether that'll help us to implement things in a clinical setting, it's still early. We don't know yet. But certainly, there's a huge potential for it. Identifying patients early of those who's going to have trajectories that are accelerated for some reason, the combination of conditions that are getting the age and the socio-demographic profile. And then if you can target certain therapies. And we are doing targeted therapies, obviously, as we've said, with SGLT2 inhibitors, GLP-1 receptor agonists. But I think there's a lot more we could potentially do if we can identify those patients who are going to have a more accelerated therapy. And we have probably the best data in the world, particularly in primary care setting. We've got things like QRisk, which uses routine data to identify people who will benefit from statin therapies. There's no reason why we can't use these data once the original data mining studies have done to say, can we implement that into our data set in a GP computer system, say who are going to get accelerated therapies and how they're targeted interventions we can do to reduce their risk. But we're still early days here.
That's really interesting thoughts about it. It's early days, but there may be some potential. So just to, it's been a very interesting conversation. I really enjoyed talking to you. But just to kind of end question is, where do you feel research in MLTC is going over the next decade, let's say? What's the future in MLTC?
Well, we've been working in the MLTC space for about 10 or 12 years. So we were very early on in that space. Most of the work that's happening is more using routine data and data mining and clustering and trajectories. What we haven't got good studies on is interventional studies. So we've got fantastic studies using the therapies we mentioned, SGLT2 inhibitors, GLP-1 receptor agonists. But there aren't any other good quality interventional studies, for example, diet, lifestyle interventions to reduce the risk of developing MLTCs or slow down the trajectory of developing those conditions. So I think over the next 10 years, we've done enough on data mining. I think we need to start thinking about doing trials to see if it can really benefit the patients themselves in that routine clinical practice.
That's really good, really interesting to be a part of it. And thanks for joining us today. And I really appreciate you coming and giving us your time.
Pleasure.
And it's been a very insightful conversation. Thank you very much.
Thanks so much.
So thank you for joining us today, and I hope you found that as interesting as I did. And please look out for our future videos on multiple long-term conditions. Thank you.